Okay, welcome and good afternoon, good morning or good evening, wherever you come from. Welcome to the second episode of the Australasian Pleural Seminar Series. This is a new initiative that we started this year to try to promote interest and better healthcare for patients with pleural diseases. And today we are very excited to have Dr. Deepan Sivakumar to join us and talk about indwelling pleural catheter. Deepan is a consultant chest physician at the Blacktown Hospital in Sydney and at University of Western Sydney. Deepan was previously the pleural lead at the St. Thomas's Hospital in London, and Sydney is very lucky to have recruited him to New South Wales. And when he was still in London, he led the OPTIMUM randomized clinical trial on malignant pleural effusion management. And it's very interesting that the hard copy was actually published yesterday in the ERJ. So hot off the press, we have Deepan today to talk about optimal care of malignant pleural effusion and indwelling pleural catheters. I want to just remind the audience that because of the large number of people logging on, you will need to put your question at chat, and we'll try to go through as many of the questions afterwards as we can. Any feedback on how we can do these sessions better is most welcome. The videos are recorded and will be put on YouTube, just like the last episode. And our next event will be in the first Wednesday of every month. So the next one will be in April the 3rd. So without further ado, Deepan.
Thank you, Professor Lee. I'll just share my screen. I believe that the host has disabled screen sharing.
You should be okay to do it now. Yes.
Okay, thank you, Professor Lee, for inviting me to talk to you all today about indwelling pleural catheters and how we can achieve a positive outcome for our patients. I have no personal conflicts of interest to declare, but I'd like to say that the OPTIMUM study that I'll be presenting was funded by an unrestricted research grant from Becton Dickinson. So for the next 15 minutes, I'll be talking and focusing on the role of indwelling pleural catheters in malignant pleural effusions. We'll be going over some of the evidence, in particular those strategies that can be used to expedite IPC removal. And then I'll finish this talk by focusing in on health-related quality of life outcomes for our patients and touching upon the OPTIMUM study, which was published in the ERJ just yesterday. So malignant pleural effusions are a huge problem. They affect nearly 100,000 Australians each year. And for the patient with a poor prognosis, they really do experience quite severe disabling breathlessness, and it impairs their physical function and quality of life. For us as pleurally interested physicians, the goal of treatment for our patients is all about palliation. It's about improving their breathlessness and thus improving their overall quality of life in their last remaining months. As physicians, we're quite spoiled for choice. There are a range of different treatment options that we can use for malignant pleural effusion, ranging from an inpatient stay for a chest drain and Talc slurry pleurodesis, having a thoracoscopic Talc poudrage during video-assisted thoracoscopic surgery, or the indwelling pleural catheter, to name a few. And our challenge as physicians is more to help navigate our patients through those choices so that they select an option that is best suited for them and their personal circumstances. As in the title, I will be focusing on indwelling pleural catheters. I would go as far as to say that, these came on nearly 25 years ago, and they represent the biggest evolution or revolution in malignant pleural effusion management since the initial use of chemical pleurodesis in the early 20th century. Now, early iterations of international guidance focused on the use of IPCs in those patients that had failed a chemical pleurodesis or those with trapped lung, as you can see with this X-ray of this patient here. But we've been lucky enough, and I've been lucky enough to be involved in a global collaborative positive research community when it comes to pleural disease. And with such high quality research output over the last 20 years, IPCs have really found themselves at the forefront of malignant pleural effusion management and are now a first-line option in the 2023 British Thoracic Society guideline for pleural disease, irrespective of the fact that whether the patient has a trapped lung or not. So what do we know about IPCs? Well, the Time2 study published back in 2012 showed that they are just as good as chest drain and talc pleurodesis at improving breathlessness for our patients. They randomized 143 patients to the IPC or chest drain and talc slurry and showed similar 100 millimeter VAS dyspnea scores at 6 weeks. IPCs are also associated with a modest but significant reduction in length of hospitalization. The ample data published by Professor Lee's group back in 2017 also did something similar, randomizing patients to an IPC or chest drain and talc slurry, and they looked at the hospital length of stay over a 12-month period and show this to be a median length of stay of 10 days in the IPC arm versus 12 days in the chest drain arm, a difference that was statistically significant. But despite this, there are some long-term risks with having an IPC. Namely, patients may experience pain related to the catheter, there's a risk of pleural infection, symptomatic pleural loculation, and also tract metastasis. And this data that was published by the team in Oxford in the UK, I think really illustrates the point nicely that there is a real burden for patients and the healthcare system. So they followed up 181 patients that had undergone an IPC insertion, and just under 10% had experienced an IPC-related infection, with 44 of that 180 needing to have an unplanned hospital visit or procedure to troubleshoot and sort out an issue with the IPC. Now, 64 IPCs were removed of the 180, so nearly 120 patients remained with their IPC and died with them. So the easy part is putting in the IPC. And in my opinion, the bit that's hardest and the thing that we need to get right is that aftercare. These things require that proactive surveillance and regular review by the treating physician. But even if things are going really well for our patients, there is still significant burden of care on patients and their carers. This is some really nice data from a group in Ontario, Canada, where they issued some questionnaires to patients that had undergone an IPC insertion. They identified high levels of depression and anxiety amongst that group, and that having the catheter reminded the patient of their underlying disease process, interfered with their sleep. And what's very interesting to me is that just over 40% of people wanted to have their catheter removed quickly. These are people that had signed up to an IPC and were well aware that it was a semi-permanent or permanent commitment. But the thing is that IPCs actually aren't necessarily a long-term commitment for our patients. We have observed a phenomenon known as spontaneous pleurodesis, where the fluid dries up, and this occurs in about a third of patients at 12 months. Now, studies have looked at ways in which to expedite and promote that process, something known as an aggressive drainage strategy. The ASAP trial, published in 2017 from an American group, compared patients with an IPC having daily drainage via the IPC to alternate day drainage. And they showed spontaneous pleurodesis success rates of around 47% compared to just 24% in that alternate day drainage arm. However, I must emphasize the fact that it took a median time of 54 days for that pleurodesis to take place. Now, the Ample2 study was published just a year later, and did something similar with some key differences. They drained patients on a daily basis, and the other comparative arm was those patients that had an IPC drainage whenever they were symptomatic. And their primary outcome measure was a patient-related measure that was breathlessness on a daily basis. And they showed that despite the drainage strategy, patients experienced similar breathlessness scores between the two groups. Yes, pleurodesis rates were much higher in the daily drainage arm, but I would argue the fact that if the patient isn't feeling much better with the daily drainage strategy, is it really worthwhile undergoing the burden of daily drainage for 50 to 60 days for that 35 to 50% chance for success? So can we do better than that? Well, just in the way that we do talc slurry pleurodesis via a chest drain, people have also looked into talc slurry through an IPC. This study is the IPC Plus study, which was published in the New England Journal of Medicine, and they took just over 150 patients that had an IPC and full lung expansion on post-IPC insertion. And for those people, they randomized them into either the talc via the IPC arm or a placebo. And you can see that the pleurodesis success rate at just over a month after intervention was 43% versus 23% in the placebo arm. Now, the keen-eyed among you will realize that a 43% success rate falls well short of the 75% that we quote for a chest drain and talc slurry pleurodesis. But the data is a little bit mixed out there. So Professor Lee has presented the epitome data at the European Respiratory Society conference. They followed up 102 patients that had undergone a sort of clinical management algorithm. So those patients that had an IPC and had full lung expansion then underwent talc slurry via the IPC, an overnight stay, and to allow for some free drainage, and then they were discharged having daily drainages via the IPC for a 2-week period. And they showed a pleurodesis success rate of nearly 75%, which is comparable to our chest drain and talc slurry data. So why is there such a big difference between the epitome data and the IPC Plus? Well, the IPC Plus data, after the patients underwent the talc, the first or following drainage was 12 to 36 hours after the installation, and then further drainage was at the clinician's discretion, but had to be at least twice a week. So I suspect with the epitome, what we're seeing is that by draining the fluid more aggressively, you're maintaining that visceral and parietal apposition in that sort of key pleurodesis formation stage, and then that is resulting in an increased success rate and a faster time to pleurodesis. But I've talked a lot about pleurodesis, but really we need to go back to our aims of treatment, and that is to improve our patients' breathlessness and improve their quality of life. So what data is there out there on quality of life outcomes? Well, we did publish the systematic review back in 2019, asking exactly that question. And we didn't find a single randomized control trial that looked at quality of life as a primary outcome measure. There really was a lack of comparative data out there for us to draw any conclusions, and multiple instruments stopped us from doing a meta-analysis at that time. So that led to the birth of the OPTIMUM study, which is a randomized controlled trial comparing inpatient chest drain and talc pleurodesis to outpatient management using an IPC and the option of talc pleurodesis. And we hypothesized that by managing someone as an outpatient may lead to superior health-related quality of life outcome measures than having a chest drain and pleurodesis as an inpatient. Our primary objective was measured at 30 days using the EORTC QLQC 30 questionnaire, which is a cancer-validated questionnaire looking at global health status. In terms of secondary objectives, we followed patients' outcomes over a 3-month period. We also looked at pleurodesis failure rate and the rate of adverse events. For our statistical power, our target was 142 patients, and this would give us an 80% power to detect a clinically significant difference using our questionnaire. We recruited over a 6-year period across 12 study sites, predominantly in the UK, as well as in Western Australia. In terms of study criteria, I won't go into too much detail about this, but we included all patients with a malignant pleural effusion with a performance status of 2 or less, and they had to have an expected survival of more than 3 months. In terms of exclusion criteria, it's all there on the slide, but I will just emphasize the fact that we didn't exclude patients with trapped lung in this study. In terms of the protocol, after randomization, patients were randomized 1-to-1 to either an inpatient stay with chest drain insertion and Talc slurry pleurodesis, as per the British Thoracic Society guidelines, or they had an IPC inserted and underwent an ambulatory pathway strategy and were followed up for 3 months. In terms of the ambulatory strategy, after the IPC was inserted, patients were then drained to near dryness and then returned on day 4 to look for the presence of trapped lung or not. If the lung was trapped, they underwent regular drainage, and if the lung wasn't trapped with full expansion on ultrasound, patients underwent a Talc slurry pleurodesis and then were revised to drain their IPCs daily and then return on day 7. And if the pleurodesis was successful, they would then return on day 14 to have the drain removed if there was no further fluid production. So with regards to our primary outcome measure, we did suffer from some data attrition. We lost about 20% of patients in each arm. So we had 58 of the 71 in the IPC arm, 56 of the 71 in the chest drain arm. But we did show that in both groups, health-related quality of life did improve to a more than clinical significant level and seemed to be sustained over that 90-day period. But as you can see from the graph, there was no statistically significant difference in outcomes at day 30. What about pleurodesis outcomes? So in our chest drain arm, we did experience a 23% trapped lung rate, which is similar to other published data. And with the IPC arm, this was also a similar trapped lung rate, but due to other complications or excessive fluid production, there was an additional group that didn't receive Talc. So just over 44% of patients receiving Talc in that arm. But when we look at pleurodesis failure, there is a real clear difference between the two treatment arms. The chest drain group experienced a 26.5% failure rate, which is very similar to other well-established published data, whereas the IPC arm experienced much higher levels of pleurodesis failure in the order of 57%. In terms of adverse events, also, I think this slide highlights very nicely the burden our patients experience with an IPC. Intervention-related serious adverse events and adverse events were much higher in the IPC arm compared to the chest drain arm, and these sometimes related to anxiety and drain-related pain. So what can we conclude? Well, both treatment pathways improved quality of life up to 90 days after intervention, but the IPC arm was not superior to the inpatient arm. The rate of pleurodesis failure was much higher in the IPC arm with more adverse events. So I think it's really important that we counsel our patients of this before electing for an IPC insertion. So really, to take home, I think that we should never lose sight of the fact that our treatment aim is to improve our patients' symptoms and quality of life, and that we should be able to offer our patients a choice suited to their personal circumstances. Now, ambulatory pleurodesis, I don't think should be oversold to our patients. If the goal of treatment is to improve symptoms and quality of life, then I don't think we should be selling pleurodesis via an IPC. But if the catheter becomes a particular problem for a patient, then I certainly think it could be visited. And just before I finish, I just want to share with you this website, mypleuraleffusionjourney.com, which is a fantastic resource for our patients. It was designed by patients for patients in the UK, and it takes them through all of the different options for malignant pleural effusion management, helps them organize their priorities, see what's important for them, and helps them in supporting them in that decision-making process. Now, the OPTIMUM trial wouldn't be possible without the hard work and dedication of such an amazing trial team. So I'd just like to thank everyone, and I'd like to thank you all for listening to me today.
Great. Thank you very much, Deepan. Wonderful talk and very succinct points. Perhaps I'll go straight to the core question while I wait for the rest of the audience. Just a reminder that if you've got any questions, please put it on the chat so that we can ask Deepan. But I'm going to start first. If, unfortunately, today you have a malignant pleural effusion, what options would you go for?
That's a really good question. So right now in my clinical practice, in the presence of expansile lung, if a patient's had some symptomatic benefit, then I would actually offer them both the chest drain and Talc slurry, or the IPC. That really depends on their social setup, their network around them, and their access to community services, whether I even put the IPC on the table, because I think it really does need that really good aftercare for it to work. But if the patient has gone for an IPC, I won't sell them the pleurodesis. It's up to them. I'd follow them up over the next month. And if they didn't want that catheter anymore for whatever reason, it was troubling them and it was amenable to a pleurodesis, then I would follow your epitome protocol, in that I would get them in for a talc slurry pleurodesis and then aggressively daily drainage them for 2 weeks in the hope that we can maximize the success of that.
Okay, so the practice depends a little bit on whether you know the patient has got a trapped lung or not beforehand, does it? In some ways.
In some ways, I mean, my personal practice would be to do a trial therapeutic aspirate in the first instance. Often patients are very early on in their cancer journey, and it might be needed for diagnostic purposes to get some cytology before committing to a treatment solution. But that's not necessarily the case. I guess the benefit of the IPC is that if you don't know and a patient wants as fewer interventions as possible and they need something really definitive done, then you could offer them the IPC and follow that through with a pleurodesis once you've, confirmed that the lung's not trapped.
Sure. One of the questions online, do you have any insight to why IPC plus Talc has such a low success rate in the OPTIMUM study?
So I think the optimum drainage protocol almost falls in amongst or between the IPC plus and the epitome data. So what we did was that we did talc people in the ambulatory setting, and they would go home straight away. And then the next drainage or that fluid evacuation would happen the following day. Now, we know from our experience with talc slurry pleurodesis as an inpatient is that there's this huge outpouring in that first 24 hours. And so I think what happened was we were losing that apposition in that key critical stage. And then when we followed it up with the daily drainage, at the time, that was the thinking, was that we were maintaining apposition through that. But actually, I don't think we did it long enough. Epitome was a bit longer at 2 weeks. And I think that enabled some success. Now, the difference between IPC plus and optimum, the numbers are more or less the same. Our definitions of pleurodesis success or failure were a little different. We sort of looked at having the catheter out because we felt like if you're going to do a pleurodesis, what you want is the patient to not have the IPC anymore. So that was our final definition. Unfortunately for our group, because there's a lot of anxiety, people get married to the IPC. What we found was that we had 13 people that we could have taken the catheter out, but 3 of them said, actually, no way, I'd rather just give it that little bit longer just to make sure that the fluid is never going to return. And because of that, it confounded our data a little bit, hence the results that we did get.
So I think that is also our experience, and also people get to a very terminal and advanced stage, and bringing them back in for another procedure to remove the IPC sometimes seems like an intervention in itself. So I think a lot of times if patients are comfortable, we just let it inside you. We got another questions. Do you have any insights to why IPC plus Talc in the OPTIMUM study was low? That was the question we covered. Why do you think IPC plus Talc, then daily drainage for 2 weeks, doesn't have a higher success rate than 75%? I think that's probably for me to answer. I think this is more about the epitome protocol. If you look at all the randomized trials in the last few years that involves Talc, whether it's this Talc slurry or Talc pleurodesis in thoracoscopy, the success rate of Talc has been around 75%. Give or take 5%. Talc is not as magical as a lot of people in the past have said. They're nowhere near 100%. 70-something% is been quite steady, the result. And also you need to remember that 75% is already in a trial protocol that most of those studies excluded people with trapped lung. So for all the people with malignant pleural effusions that walk into your office, the actual number of people that will have successful talc pleurodesis will be even much lower. Yeah. So probably from a trial point of view, Deepan, I know that the OPTIMUM trial was a hard work for you, and it took quite a few years to actually recruit to the full enrollment. Any advice and anything, and any reflections on, a lot of the young people who loves to do randomized trial? Any word of advice?
Yeah, thanks, Gary. Yeah, I mean, I think anyone who has been involved in delivering pleural disease trials will testify to the fact that whilst we're trying to answer these really important questions, they are all really tough to deliver, require a lot of perseverance and dedication. I guess the reason being is that our patients are really frail and the interventions that we offer are really complex. And whilst I think OPTIMUM was really hard to recruit to, and it did take me the best part of 6 years to get across the finish line, I do see it as a big success, mostly because we involved patients, much in the way that you have done as well for your other studies, early on in that trial conception point of view. Patients were directly involved in selecting the questionnaires, telling us when too much follow-up was too much. And that, I think, really helped get this over the line, but also just collaborating as a big pleural network. We had 12 sites, really interested people, passionate about pleural. And I think if you can be really passionate about research delivery, then, relying on that big global network, I think it's a fantastic resource in order to deliver for our patients.
Yeah, absolutely. I think a lot of times doing clinical studies about the journey, not necessarily always about the end product. Can I ask you, you chose the health-related quality of life as the endpoint. In patients with advanced cancer, often there's a lot of elements other than malignant pleural effusions that affects their quality of life. Do you have any thoughts about how much of that could be influenced by other things happening with their cancer that affects their quality of life in the trial?
Yeah, I think that's something that I've learned a lot from delivering this study. We're delivering one intervention which is actually perhaps a small slice of that bigger cancer journey that our patients are undergoing. Many of them receiving multimodal treatments, having a different experience of their cancer pathway, some receiving bad news, some receiving better news. And certainly it can be tough to pick out the signal as you progress down that cancer journey. And I think that's also something that we found with the OPTIMUM data. Now, the cancer questionnaire that we used is validated for advanced cancer, but it isn't a specifically designed tool for malignant pleural effusion disease. And I really think that that might be the next step forward for us as a pleural community to band together, try and understand or better understand the aspects of care that directly relate to malignant pleural disease, and sort of see if there's better ways of teasing that out in and amongst the cancer journey.
Okay. Someone must have studied your protocol carefully and say that in your original protocol you included manometry. What has happened to that, and any useful data out of it?
Yeah, thank you. So we did use manometry. That was more as an outside outcome beyond the remit of the study. We use, just to explain to everyone, when patients underwent that initial drainage, we would hook them up to a pleural manometer, measure their pleural pressures, and try and achieve a complete drainage, and seeing if we can use pleural manometry for two reasons. One was just to ensure some safety with large volume drainage, because the data at the time would have suggested that might help guide you. And then the fact was just out of interest to see if it was a good predictor of trapped lung. And I think our experience, although I haven't published this data, is that well, we found it very difficult to deliver pleural manometry across multiple centres. There was only a handful of centres that had good experience that were giving us reliable data. So we had a lot of data attrition with regards to manometry being performed, but also it didn't really serve as a good predictor of, of the experience. What we found was that patients experiencing pain was actually a reason, was the sort of earlier reason to stop drainage rather than the pleural manometry.
Another person who studied your protocol very carefully is ask you, what happened to the lung sliding assessment that was in the protocol? Did you find it useful to predict the pleurodesis outcome?
Yeah, so the criteria for pleurodesis success rate was looking at pleural apposition and lack of lung sliding in 5 of 6 zones at the day 7 assessment. This is very similar to the published data from the SIMPLE study by Yannis Salidis' group in Oxford. And so our data and our protocol was very similar, in some ways similar. Now, our trials were conceived at separate times, hence the differences in the protocols that we do use. But essentially our measure of pleurodesis success rate was using that ultrasound. So the data that I'm presenting is a function of that.
Okay. Does the primary cancer of the effusion influence the success or any of those outcome measures?
So we did look into subgroup analysis for cancer type, and patients were stratified with their randomization between the 2 arms, so it was fairly evenly balanced between the 2. We didn't see a signal that related to primary tumor type and quality of life outcomes. We didn't specifically look at pleurodesis success rate because the numbers were a bit small at that stage.
And one question is that one of the potential advantage for upfront IPC plus or minus pleurodesis is that you reduce the overall total number of pleural interventions and procedure. Was that the case? And if that is the case, why do you think the quality of life did not get reflected in the final outcome of the study?
So I agree. I think it is the case that if you're doing an upfront first line IPC prior to assessment of trapped lung, that we know that we're reducing the intervention rate for patients. I guess the thing is that it depends on what for our patients is, in terms of their quality of life. Do the interventions actually, the additional interventions, impair that? I would argue not, because you're relieving the breathlessness straight up front. Patients get better almost immediately or the following day. You get this huge lift in your quality of life, which is then sustained. I think because the OPTIMUM study comes in at the point where the IPC is inserted, we obviously don't have the data for those that had multiple interventions prior to being enrolled in the study to say or suggest whether or not whether that journey had affected their baseline or starting quality of life. Okay.
I'll probably come up to the last questions about infection. Did you see a lot of infection, and when do you actually remove the catheter if you got an infection?
So with pleural infection rates, our rates of infection were similar to other published data. I think it was in the order of 4 or 5%. But in terms of removing the catheter, we very rarely remove the catheter because of infection. I don't think we removed the catheter for this study, but I'd have to double check the data. Yeah. In my own practice, we treat it like an infected peritoneal dialysis catheter. You give them IV antibiotics and then transition to a long course of oral antibiotics. And that usually is enough to manage the infection and then continue with the drainage.
I will allow one last question. So how often did symptomatic loculated pleural space requires drainage after your Talc plus IPC? So do you see a lot of loculated effusions, which is what people are concerned about when you give Talc through IPC? So we did see some symptomatic loculation requiring another intervention. I think it was in the order of 3 or 4%. That is, in fact, a little bit lower than other published data. Because my own practice, and usually what I say to patients, if we're doing Talc via the IPC, I usually quote about a 10% chance of symptomatic loculation for those patients. So it was a little lower. I can't explain the reasons for that. That might just be due to patient selection. Yeah, excellent. Okay, I think we've way over time now, so we'll finish here. I'd just like to thank Deepan again for excellent discussion and presentation. I'd like to thank everyone who has logged on. I'd like to ask everyone to give us feedback and any suggested topic. Remember that the recording will be available on YouTube for any of your colleagues that could not log on today. And our next presentation is April the 3rd. Thank you very much for attending, and see you next time.